Good afternoon, all. Thank you for joining this Hamlin Symposium workshop, which is entitled Towards Tumour Margin Assessment Using Raman Spectroscopy. For anyone who doesn't know me, my name's Alex Thompson. I'm a lecturer at the Hamlin Centre, doing a little bit of work with Raman Spectroscopy by myself. And I'm going to be the chair of the session today. So I'll just give you a little quick intro and then we'll get started sooner rather than later. So today we're going to have three talks from three very distinguished speakers that we're happy to have with us. One of those will cover the sort of clinical motivation for this workshop with a particular focus on breast cancer, and then we'll also have two talks more technically focused, looking at the use of Raman spectroscopy for both for cancer diagnostics and for other applications as well. While you're listening to the talks, obviously if you have any questions, please just use the Q&A function at the bottom of your Zoom window there. And if you leave a question there, then I'll ask that either to the speakers at the end of their talks or at the end of the workshop, where we'll have a panel discussion. So we'll have the three talks and then we'll have the panel discussion after that. And that panel discussion hopefully will focus on the progress that's been made with Raman spectroscopy and its applications to cancer, but also on the challenges that remain in obtaining further clinical penetration. Our next speaker is Mr. Daniel Leff, who's a breast surgeon and a reader in breast surgery here at Imperial College. And Dan is going to give us the clinical perspective behind this workshop and the clinical motivation behind this workshop, really, with a particular focus on breast cancer. So Dan, over to you.
Many thanks for the introduction. Hopefully you can hear me, Alex.
Yep.
I'll attempt to share some slides. Hopefully that will work. Hopefully you can see my screen. Yep,
we've got it.
Excellent, great. So as Alex says, I'm just going to try and just give a little bit of the clinical motivation for this, particularly in the area that I work in, which is breast cancer surgery. So with respect to breast cancer surgery, what are the options? Actually, it's reasonably straightforward. It's really either excise the tumour and preserve as much breast tissue as possible, or else mastectomy. Sorry, bear with me. And it goes without saying that in terms of quality of life, there are advantages to keeping as much breast tissue as possible certainly over a simple mastectomy, and possibly even over mastectomy with reconstructive surgery. So what's the problem with trying to sort of keep breast tissue and avoid mastectomy? Well, one of the problems that we face not infrequently in breast surgery is illustrated on the screen. Of course, we're aiming for a negative margin, that is a certain distance of healthy breast tissue between the edge of the tumour that you can see there and the normal tissue. Far too frequently, we encounter a situation where the tumour is either right at the edge, as illustrated on the screen, or too close to the edge. And then we don't know, are there cancer cells remaining inside on that breast cavity from where the tumour originated? Why are close positive margins of significance? I guess it goes without saying, you won't be surprised to see this data on the left of the screen, that if you have a positive margin, you're at significant increased risk of locally recurrent disease. And hence those patients where the margin is too close for comfort tend to have re-operative surgery. What is the scale of re-operative intervention in the UK? Well, this data is taken from Jeevan et al. A little bit old by now, but I guess the recent Get It Right First Time report will almost certainly corroborate that this is still the case sort of 10 years later. That the national average re-operation rate after breast conserving surgery is 20%, and that's average. So that's pretty high, and you can see that it doesn't necessarily have a relationship with the volume of primary breast surgeries being performed. So it's a big problem in terms of far too frequently needing to go back to surgery. I guess the other problem is when we do go back to surgery, as you can see here from our own data at Imperial, this shows you whether we found residual disease or not when we went back on those patients that had close positive margins. And you can see that approximately 50% of the time, regardless of the width that we used, whether it's involved or close positive to 3 to 4 millimeters, it was a flip of a coin whether there was any further disease there or not. So we're subjecting quite a proportion of women to, you could argue, unnecessary reoperative intervention. What's the volume? Well, approximately 11,000 women per annum approximately being returned to the operating room, so not small. It goes without saying that from the patient's perspective, it's not a particularly good situation to be in to need re-operative intervention. But to summarize, there's obviously a psychological morbidity with anxiety and stress associated with re-operative intervention. If we go back and do further surgery to the breast and take more tissue away and still try and conserve the breast, we know that it leads to inferior cosmesis with greater volume. Each time you're taking more and more tissue away, the worse and worse the breast will appear, and that has an impact on quality of life. If patients are stuck in a pathway of re-operative intervention, they don't move forward into the other adjuvant therapies that they might need, like chemotherapy or radiotherapy, for example, so their whole pathway gets delayed with potential for adverse oncologic outcomes. It is an extremely costly problem to the UK as well, and internationally, the re-operative intervention problem. The truth of the matter is actually we don't really know what the cost of re-operative intervention for this problem in the UK is, but it's estimated to be the figure that you can see on the screen at the top, based on just conservative estimates of just the direct cost of re-operation. So that's likely to be a gross underestimate. Why do we find ourselves in this specialty, in this situation? I think it's true to say that in other types of cancer surgery, we don't see such high rates of positive margins needing to go back to surgery. Well, undoubtedly, it's a function of the MDT working, the surgeon's perceptual skills, radiology, localization of disease. We are seeing increasing burden of clinically occult disease. So that's disease that the patient can't feel and the surgeon can't feel. Hence, it's very difficult to get guidance around removing something that really you can't see or feel. And the fact that we're in an era of oncoplastic surgery where we're very concerned about the cosmetic outcome might lead to us to rein in on the resection margin, and hence the possibility of risking further positive margins. Setting today's workshop into some kind of context, what are the potential options for managing this issue? Well, there are the traditional techniques, so-called frozen section imprint cytology. I'll present very brief data on that in a second. You could just keep on taking more tissue away at the time, and I'll present very briefly on the landmark trial in that space and why we think it's possibly not the right way to go. There is some suggestion that if you adjust the positive margin rate or the acceptable margin width on the basis there is no evidence for a very precise margin, that you might be able to rein in on the proportion of women going back to surgery. And then there are the novel interventions such as the one we're talking about today. Shave margins, what does that mean? That basically means essentially doing full cavity shaves around the primary tumor, here seen as a pink resection. So that's your initial resection. Colleagues randomized to either no shave or complete cavity shave. You can see here on the right that they can reduce the re-operative intervention by 50%. The problem is, again, by doing these routine shaves, you've got a substantial difference in the volume, and we know that's going to have an impact on cosmesis downstream. When it comes to competitor analysis, I guess you would call it, you won't be surprised to see that the cytology and frozen section, that's FZ, have the highest sensitivity and specificity in pooled analysis that we performed relatively recently and published. And here is essentially the SROC curves for both those techniques, frozen on the left, imprint on the right. You can see the area under the curve is almost 1. So these are the techniques that work really well. Why don't we do them? Well, our pathology laboratories don't look like this, certainly not in the UK and certainly not in Imperial. You tend to have two pathologists sort of working their way through all of the breast specimens that we have, whether it be diagnostic cores or the post-operative resection specimens. So frozen section is time consuming, it's costly. When we surveyed the big 18, 0 centers, no one is doing this in the UK in terms of immediate histopathological assessment to guide the surgeon or guide the surgery. What other things are in routine use? Well, we take the specimen out. You can see it there as an X-ray specimen on the screen. You can see the marker coil and the wire that's guided the surgery. This is quite commonplace in a lot of centers in the UK. And you'll see here from the SROC curve that actually it doesn't work especially well in terms of sensitivity and specificity for margin detection. And yet it's in routine use. Intra-operative ultrasound has gathered some momentum in certain quarters. Again, you see there that the sensitivity and specificity, or certainly the sensitivity, is not especially good. We know that ultrasound is very operator dependent. And I guess this has led to an explosion in this space. Of course, we're talking about Raman spectroscopy today, but hopefully you can see on the screen that broadly this is imaging, some sort of system where you put the specimen into either a micro CT or MRI to get some information. lots of optical systems that you're seeing there on the screen, all of which would be competitor analysis, I guess, or need to consider how they would work together with Raman, bioimpedance and mass spectrometry. Probably the front runner is margin probe, which some of you may have come across, radiofrequency spectroscopy, where it's able to tell the difference between normal and cancer cells based on differences in the nuclear morphology, vascularity, and the cell-to-cell connectivity. What you're seeing on the right of the screen in the bar charts are really randomized control studies with the first author named. The difference is shown between the re-operation in the control setting, so that's standard, whatever guidance we use presently, versus margin probe re-operation rates. You can see that margin probe does substantially reduce the rates of return to theatre, and in some trials quite significantly so. We're, as well as investigating Raman spectroscopy here, we're also working on the iKnife, so that's rapid evaporative ionization mass spectrometry. So electrocautery vaporizes the tissue. That's essentially a cloud of ionized particles, which we're sending to the mass spectrometer in real time towards this rapid, accurate, real-time, clinically actionable information. I think the only last thing to say that I want to say is that all of this really needs to be set in the context of workflow and integration into the clinical workflow. iKnife, of course, is going to give you information in approximately 1.8 seconds. Other systems that involve holding a probe to the tissue are going to be inherently slower, but still, in my view, are going to have a tremendous impact. Many of these systems will probably work together in some way, shape, or form. And anything that requires transfer of the tissue out of the operating room, I think, is probably historic. It's going to be 30, 40 minutes plus, and the pressure on operative time is such that we're not going to be able to rely on those systems. Many thanks for your time.
Great, thanks very much, Dan. That's a lovely talk, giving a really nice overview of the motivation and the various different technologies. There's a lot of different technologies being used in this space, so it shows that there's real opportunities there. So again, just to the audience, please do put your questions in the Q&A section if you have any. Again, I can come back to them if you think of them later. We can come back to them in the panel discussion. While we're waiting, Dan, I'll just ask you a couple myself. So you mentioned at the end there that you think that any technique that requires samples to be sent out of the operating theatre, even if it's for 30 or 40 minutes, that's not really going to cut the mustard in the future. What we need is tools that can be used at the point of care, either intraoperatively or in the operating room at the very least. And that's
I think that's my view, Alex. I think that technologies that rely on something to leave the operating room, definitely, or that the surgeon isn't able to sort of engage with in some way, shape, or form, are probably not going to gather huge momentum. Anything that relies on pathological cross-referencing is probably not going to work either, I doubt. Certainly not in the UK. There may be certain centres in the world that are able to do that, but I don't think we can do that in the UK. I think the technological solution has to be reasonably quick to give an answer, ideally, and it's also the integration. Some of the challenges with systems like ClearEdge, for example, which is similar to margin probe, and indeed margin probe, is the potential to either rescan areas that you've already scanned, or the possibility on relying on some human interpretation of readouts to a certain degree. So I think if we can move to a situation of wide field scanning of some kind, some sort of automated system that doesn't rely on surgical interpretation too much, in my view. Yes, for the enthusiasts, we'll stay there for hours trying to do it, of course. But I think if we want to get a technology to disseminate and become routine, it's really got to integrate well in the clinical workflow. I think that's borne out probably.
Yeah, absolutely. And Dan, just on that point, maybe I missed this in your talk, but would I be right to say that there are really only two technologies that are in reasonably widespread use at the moment in an intraoperative sense? I think you mentioned intraoperative ultrasound and radiology as well for in the operating theatre measurements. Beyond that, things like margin probe are still at a very early stage. Is that fair?
I think that's really fair. I mean, I think people use specimen X-ray very frequently. It's very good for saying, the lesion that I was trying to remove with the marker clip is in the center of my resection. It's not so good at telling you really about the edge and how clear you are as a distance from the tumor to the normal, which is what we really care about. I think that's now probably broadly accepted as well by colleagues, that they're not really using it quite as much for that. The intraoperative ultrasound is used by some, but not many, truthfully. It's got some good results in trial data, but it's not in widespread use. Frozen section and imprint cytology, which I presented there in terms of our analysis, show to be, they're really good techniques and they work well. It's just that you don't have the woman or manpower to sort of, to do that, and hence the need for a technology solution, really.
Yeah, great. And yeah, as we say, lots of opportunities, but lots still to be done as well. We've got one question just come in, which is around the use of radio frequency spectroscopy. I think in the interest of time, we'll come back to that one in the panel discussion if we have time, actually, because we're now a little bit behind. So we'll move
no
to
problem.
the speaker.
Thanks very much.
But thanks very much, Dan, for a great talk, and we'll see you again in the panel discussion. So Steve, if you could now spotlight Anita, who is our next speaker. Our next and final speaker is Professor Anita Mahadevan-Jansen, who is a professor of biomedical engineering at Vanderbilt University in the US. So thanks very much for joining us, Anita. And Anita today is going to tell us about some of her work deploying Raman spectroscopy in vivo for a range of different clinical applications, spanning from everything from pregnancy through to cancer. So Anita, over to you. I think you're muted, Anita, just in case you haven't spotted that. Anita, you're still on mute. If you, yeah, there you go.
I lost my slides.
We can hear you now, but can't see the slides.
Just give me 1 minute. When I try
right.
to switch from unmuting, I closed my slides, so now I got to find my slides again.
That's all right, no problem. No problem at all.
You come in prepared, ready to go, and then one small thing, like you are muted.
Yeah, throws you off.
Plan up very, very quickly. But thank you for asking me to join in. I know you asked me quite a while ago, and I had no idea what my schedule was going to be like. So I do appreciate being here, and look forward to the discussions that that I hope we'll have here. There we go. All right, now let me see if I can share my screen.
It's already up for me. I think you just need to.
You can see it. Oh, if you can
play
see
on the slides. Yep, there you go.
Okay, perfect. So when Alec and Young asked me to present, I was like, okay, what would you like me to present? And the topic was surgical guidance, and we certainly do a lot more than that. So after hearing what the other speakers, my slides are a slightly different angle, and I hope you'll bear with me, and I hope it provides you with enough food for thought. The fundamental premise about what we're talking about here is that light can be used to sort of detect tissue physiology and pathology, and can be used in a meaningful way to really do that quick assessment. You heard that from Matt, you heard that from Dan, as well. And I like to focus on native contrast methods rather than methods that involve nanoparticles, contrast agents, and so on, because it's a lot easier to do the clinical translation. And when you think about that, you go, okay, clinical translation is great, but how about some of the fun stuff? And there's these techniques that we talk about are used for lots of things. Evaluating wine, it's something I've been doing actually recently for looking at wine quality. You can certainly evaluate whiskey. It's evening for you, so it's time for a happy hour and a drink probably, and you can certainly use these techniques to do those to look at more consumable products. But when we talk about clinically, you heard a lot about surgical guidance, but there's various aspects of evaluating tissues, especially when you're trying to do things clinical. You can do diagnosis, which I think is probably the most difficult problem. And historically, a lot of these techniques are primarily used for diagnosis of optical biopsy. That's probably a phrase many of you have heard. The problem with diagnosis is that typically you have to, if in a given disease or condition, your technique needs to be able to recognize a wide range of pathologies, benign, malignant, but everything else in the middle that might require treatment. Because in this situation, you really need to know what it is. Otherwise, you end up having to rely on histology, then why bother? This is what has made it very difficult for optical techniques to break the barrier, I think, of optical biopsy, because physiologic variability and heterogeneity causes a challenge. So many, many, many years ago, and I would date myself if I told you when I first started working on surgical guidance, I started working in guidance because it honestly is the easiest problem. In there, you really want to discriminate between what's normal and what's the thing you want to remove, typically malignancy, but not necessarily so. And you need that line so you know to maximize the removal. You don't have to worry about all the different pathologies. You just need to know what's not normal that's coming out and what needs to stay. The confounder there, of course, tends to be blood, but there's ways to work with that. Screening, where you're evaluating to see is something not normal and needs to be taken care of, is somewhere in the middle between diagnosis and guidance, where you need to determine something that's not normal, and from there you would go typically to a diagnostic phase. And certainly some of you might have heard a lot about sensing, where you want to actually know, quantify certain analytes and so on. So there's this wide spectrum of ways in which you can use these different light-based technologies for it. And there are certainly lots of different technologies. You saw a laundry list on breast cancer. There are more. Don't worry about reading all the different techniques. It's not a comprehensive list, by the way, but all of these techniques rely pretty much on 4 different phenomena: absorption, fluorescence, elastic scattering, inelastic scattering, and some maybe a refractive index mismatch. And so all of these techniques, though, one of the main things to remember, they all have their pros and cons. They don't work for everything. Absorption provides functional information, but spatial resolution often suffers, especially in the IR. Water is a problem. Doing in vivo is a challenge. Fluorescence is excellent for malignancy versus not, but typically suffers from poor specificity. Elastic light scattering and diffuse reflectance provide structural information and a measure of tissue optical properties, but not necessarily functional information. Raman spectroscopy certainly gives you a molecular fingerprint and can do great for differential diagnosis, but it's weak, and in vivo, you've heard 2 seconds. It depends on the challenge as to how you implement it. So each method, and this is not all the methods, I'm just presenting 4 different methods. So you both certainly should look them up if you don't know exactly how these things work, but I'm going to presume you can do that in the interest of time. So each method provides critical information, but is not omnipotent. It won't work for everything. So in my lab, what we've really done is use what we call a pedagogical approach to research, kind of the way you do for learning, or what I'll call problem-based, right? Which is understand the problem, the clinical problem, understand what is necessary to solve that problem, and then choose the technique that best fits solving that problem. So I'd rather not be a hammer looking for a nail, but design my hammer based on the shape and form and size of that nail. So that's sort of one of the things I do tend to preach. So my apologies for doing that. But it's a common problem because it also hinders the development and the pushing of this technology, the translation of these technologies for in vivo medical implementation. So I'm going to try to give you 2, maybe 3 examples. I'll try to keep them short and go through. If you have questions, feel free to ask me later, so that you can kind of get a sense how we tackle things. The first one I'm going to give you is actually one for sensing hydration. So hydration is something that's closely related to fatigue in high performance athletes. European Cup soccer is going on. Congratulations, by the way, to England for winning yesterday. The Olympic trials are going on all over the place, with the Olympics coming up very, very soon. The Tour de France is going on. And if you've seen all of these athletes, hydration is key. Fatigue and their human performance is directly linked to hydration, and deviations of even 2% from normal levels can negatively affect a person's performance, both cognitively and physically speaking. Certainly chronic hydration can have all kinds of problems, and it's been linked to, key role to play in cancer, pregnancy, and other conditions. Clinically, the only way to really evaluate hydration is by looking at the color of urine. I mean, literally take a color chart and put it next to the color of urine to determine where you are in your hydration level, or actually do a blood draw and do serum analysis. Many people have been looking at using various methods, and the latest Apple Watch, for example, claims to be able to do some hydration assessment. It's based mostly on electrochemical assessment of sweat. Impedance is another method, use osmolality. There's lots of methods out there, but realize that all of those methods tend to measure the indirect phenomenon as an increase in electrolytes or of salt in order to determine hydration. But what if the reality is you need to be able to find, because by the time you feel dehydrated, it is too late. You need to find out when you're dehydrated well before you feel dehydrated in order to have an impact in real time. So when we started looking at optical methods, like, well, FDR can quantify water, but I can't do it directly in the athlete. It's non-trivial. Raman of water is certainly feasible and has a lot of information. So we decided to attempt that using high wavenumber Raman spectroscopy, which has clearly very distinct bands. You also have 5 different bands you can look at, which is partially bound water versus free water versus fully bound water, which might really give you that early signals that you're looking for. So with that in mind, we and this is just showing you all the different peaks, we decided to pursue that. And we built a system that is essentially a dual wavelength system. The goal of this system, this is a benchtop system or a cart system, if you will, right now. And our goal is to build a wearable around it in the next couple of years. But for right now, what we do is we're doing dual wavelength, as in we're doing both fingerprint Raman as well as high wavenumber Raman using the same system, just by changing the excitation wavelength, so that we can get spectra. This is for a gelatin-water combination that you see here on the left, what that looks like for as you change the level of water in that gel phantom in the fingerprint region as well as the high wavenumber region, and really get a calibration curve that beautifully fits, that lets you quantify hydration. We've now done this in vivo in a pregnant mouse to show that you can see a difference in partially bound water, especially as a function of pregnancy. And we are in the process right now of designing that we built a system and designed the system to measure athletes right now. They're Vanderbilt University athletes, and we're looking at the baseball team. If you follow baseball at all, the Vanderbilt team actually is in the College World Series right now. So waiting for them to come back from the College World Series before we start measuring them in their postseason training period. And we are also measuring pregnant women over the course of their pregnancy to see if we can use that as an indicator and develop it. So this is an example of working our way through hydration as a problem. Let me give you 2 other quick overviews. One is for doing preterm birth detection. Preterm babies, who can be as small as the size of your hand, is significant. 15 million preterm births occur each year, globally speaking, and is a direct cause for about 1/3 of infant mortality rates. Preterm birth, by the way, is defined as any baby that's born before 39 weeks, and many are born as short as 24 to 27 weeks. Those are truly preterm. And despite very significant advances in neonatology and obstetrics, very little really is understood about labor and parturition, or the pregnancy process. We look at the cervix and the cervical remodeling during pregnancy, and what you find is that the uterus and the cervix especially changes quite a bit over the course of the pregnancy cycle, and we can evaluate each of these cycles over the course of pregnancy very well by looking at the cervix. It's kind of like a window into the pregnancy. And we want to do this very clearly, non-invasively, in vivo in real time. My lab, actually my PhD work many, many years ago, was on using Raman spectroscopy for looking at cervical dysplasia or precancers in vivo. And when we did that study, what we realized was that Raman is very sensitive to hormonal changes. And so you certainly have a way, the biggest hormonal change a woman's body goes through is pregnancy. Therefore, we have a way then of using Raman. It makes sense to use Raman over other techniques to really follow pregnancy and see if you can identify changes in the trajectory of change that occurs over the course of pregnancy that might be indicative of the cervix trying to give birth too quickly. The kinds of changes are going to be things that we need to be sensitive to: are collagen, elastin, hydration, glucosamine, aminoglycans, and prostaglandins. And so we've done this. We've developed a system, in vivo system, with a fiber optic probe that is introduced within the cervix, and we make multiple measurements over the course of their pregnancy, across all 3 trimesters of pregnancy, as well as labor. We published work on about 68 patients, and we've actually got probably about 30 or 40 more that we've measured. And you can really see, here's an example of, how the cervix changes over the course of pregnancy. And, we measured this across all the patients. So we've got stacks of spectra across multiple patients to evaluate. And what we found is when patients have had prior pregnancy, the spectra shows that changes. Patients second time and multiple parturition moms, their cervix is sort of primed. The instant they're pregnant, the changes that they go through over the course of pregnancy are relatively small compared to someone who's going through the first pregnancy. Makes logical sense. When you look at patients who have a high body mass index versus normal, another case where the process is much slower for high BMI patients, which is perhaps indicative of why BMI patients tend to have harder time delivering their babies, because it's just, the cervix just takes a lot longer to remodel. We've also looked at changes during labor, and we see some interesting changes as a function of lipid peaks that we're still trying to figure out. And then right now we're in the process of essentially recruiting those preterm birth patients to see if we can identify which patients. We've got preliminary data that indicates we can predict 2 weeks before the mother goes into labor that we can detect them. And since the previous speaker spoke about surgical guidance of concept of breast cancer, I have 1 slide or maybe 2. The motivation here, of course, you've heard plenty that, breast and lumpectomies have the same long-term survival rate as total mastectomies, and so lumpectomies are more and more recommended. And there are 2 ways in which you can address this. You can evaluate the patient in vivo into the body, or you can take that excised lump and evaluate that and see, is the boundary still tumor, or is there normal, so that you've removed all the tumor. Right, at least in the United States, the success is determined by what's called ink to margin, that you ink the margin, and beyond the margin, that ink, it's normal. And so when we looked at this first, there were actually only 2 other groups working on doing surgical guidance for breast cancer assessment. Clearly now there's a lot more people working on it. But identifying negative margins is an important fact. What we did was we compared various techniques to identify what works best. We realized here, if you're looking, we decided to go to the idea of looking at the lump. And if you want to look at the lump and all this around the lump, you've got to have coverage of this 3 to 6 centimeter lump. You also have to be able to have resolution of 1 to few cells, which is about 100 to 200 microns. And you need to be able to go 1 or 2 millimeters in depth. Based on this, we developed a method of using spatially offset Raman spectroscopy to look in depth and evaluate the entire lump in less than 5 minutes, automated. That's a 3-dimensional scanner that we've developed with co-registration with white light imaging, so that we know exactly, we can map 1-to-1 the anterior, posterior, ventral, dorsal sides of the lump coming out of the patient as we do. And this is being evaluated as well. So with that, I'm going to stop and say, following a problem-based approach to research and develop targeted solutions to medical problem allows the technology we want to develop, in this case, we're talking about Raman spectroscopy, to make a bigger impact sooner rather than waiting well beyond my lifetime for it to make a difference. Optical methods in general certainly can have a significant impact in clinical care, but I think Raman is challenging, extremely challenging, and therefore identifying its unique capabilities and matching it to the clinical problem is the way to maximize successful implementation of this technique. With that, I want to thank my group. I've talked about all kinds of students' work here, all kinds of clinical collaborators and funding sources at work here, and we'll let us go to the panel discussion so we can ask questions. Thank you.
Many thanks, Anita. Another really fantastic talk and some really interesting stuff in there. If you could just stop sharing now, perfect. And then Steve, I think it probably makes sense if you just spotlight all of the speakers now straight away, and we'll move straight into the panel discussion. So again, to the audience, if you have questions for anyone now, please just pop them in the Q&A section, and I will ask those to all of our panelists. While we wait for that, let me just start with a few questions for you, Anita, specifically on your talk. So yeah, it's really nice to see the variety of different clinical applications you've looked at. Just a couple of quick questions, really. With your Raman Spectra, your cervix Raman Spectra, looking at pregnant women, you mentioned lots of things, differences you could identify and that sort of thing. Have you looked at identifying, for example, women at high risk of complications during pregnancy and that sort of thing?
Right. So we are recruiting high risk patients right now. Right. These are patients, short cervix, and there's so many different indications of why they will go into preterm birth. And our focus right now is a couple of these different etiologies, not all of them, so we can see, but our prediction is that the trajectory is going to be affected, regardless of what the purpose is. We're not using this to identify what's the problem, just do we know they're going to go into labor soon, so can we stop that from happening so the baby can stay in there longer, improving their survival rate.
Okay, yeah, sounds good. I mean, I obviously don't have a huge amount of experience in this area, but the little experience I do have with pregnancy and things, women get exposed to some really quite invasive tests actually throughout the course of pregnancy, and so it's nice to have a less invasive approach that can identify these things. So we have a question for Anita in the chat, so let me ask that one, and then we'll move on to a broader sort of panel discussion. So, question for Anita: the depth profiling of the tumor tissue, which wavelength did you use in Raman? Was it 785 nanometer laser?
Yeah, so pretty much everything we do for in vivo clinical work, except where I showed the dual wavelength lasers at 785, so we can still use silicon-based detectors, which is where the technology is furthest along for doing this. 830 just gets us to push too far in where we can't get meaningful spectra in the range that we're looking for in vivo, so we tend to go with 785.
Great. And a follow-up question to that from me, Anita, with your dual wavelength system that you described there, you have 680 and 785 in that system. Why have you gone for 680 there? That's not the most common Raman wavelength, right?
Right. It's about the detector. If you look at your detector in nanometer range, the detector looks roughly between 800 and 1,000 nanometers. So if I use 680, 800 to 1,000 nanometers becomes that 2,400 to 4,000 wave numbers. If I use 785, that same range is my fingerprint region between 600 and 2,000 wave numbers. So my detector stays fixed, my grading stays fixed. The only thing I do is flip-flop the laser to get both spectra. That's why we pick 680. It's a question of the detector range of the spectrum.
Yeah, no, that makes sense. Great, thanks. Okay, brilliant. So again, just please do pop your questions in the Q&A session. While we're waiting for those, I'll just maybe start to ask a few slightly broader questions focused on this idea of trying to use some of these technologies for tumor margin assessment. So Dan, maybe if I could come back to you first. And we did talk about this a little bit after your talk, but if we're thinking about trying to use Raman for tumor margin assessment, what do you think is an approach that would be useful in your case in breast surgery? Do we need to be developing a probe that can be used in vivo to scan tissue before you resect it, or is a probe or a system that can be used ex vivo but in the operating theatre enough, if that makes sense?
Yeah, it does. I mean, I think, don't get me wrong, I think having information as you go is helpful, because of course you can modify your resection routine, if you see what I mean, live. So that would be incredibly helpful. But equally so is being able to scan the edge. And I was very interested by Anita's talk in terms of the depth resolution, of 2 millimeters, because I think that's probably also raised by one of the listeners as well, in terms of the depth, because of course the DCIS is what gets us in the main. It's not so much the invasive tumor, although that can be a problem. It's more the DCIS, which in the US they're using sort of 2 millimeter. They want 2 millimeters, in other words, between the edge of the DCIS and healthy tissue. So you've got to have a system that's got that resolution, I guess. So yeah, something that could provide reasonably swift, I know it seems like a high bar, but reasonably swift whole specimen scanning to the depth resolution of 2 millimeters would be absolutely fantastic. And the image that Anita showed was really, if you could have that presented to the surgeon, in the operating room, that they could rotate round, it would be a dream come true in many ways.
Yeah, I should say that video that had that picture I had of the entire lump is rotatable. I just did.
Yeah, I was curious, Anita, about how long because I know these things that take, you know, it's not trivial, right? So as you were saying, it's very complex, difficult stuff. So how long does it take to develop that sort of, you know, that image, or, you know, how from the start of the, you know, collecting the data on the specimen to producing such a thing, how long has that taken in the lab to?
It of course depends on the size of the lump. That particular picture was for a 5 millimeter lump, and that took about 5 minutes to produce in real time. You know, get the scans, do the processing, co-register with white light image, and present that to the surgeon, roughly just under 5 minutes.
Yeah, so that's pretty swift, yeah.
Yeah, exactly. That's getting to be pretty fast, though, isn't it, really? And so, Anita, with that, just a very simple question. That was all tissue samples that you were taking from the operating theatre and taking to your lab. You weren't set up.
No, it's in the OR.
It's in the OR as well. So you're set up doing that.
Yeah, that's one of the nice thing at Vanderbilt is we have the luxury, we get IRB approvals. It's a little bit easier than honestly the approvals it takes in the UK. And I can just go in the OR. They give me the lump, the surgeon puts it in place, we scan it through, and then just immediately send it to path. You know, then they ink the different surfaces. This is how they do it here with the suture at the 12 o'clock position, and they send it off, and then we get real-time histology of as many spots that we've identified in the lump, so we can do histological correlation of how accurate we are in our assessment.
No, that's great, and it overlaps really well with the types of things Dan was talking about, right? With technologies that can be used in the operating theatre, give an answer in a few minutes. It's, you know, we're getting close, really. We have another question from the audience. Could Mads give a bit more information about integrating filters with optical fibers, please? It's been said that Raman probes need special manufacturing methods in terms of integrating filters with compatible fibers. What special methods are being used? So Mads, over to you on that one, and I'll just preface the answer by saying we only have 2 minutes left, so let's keep it reasonably brief.
With regard to manufacturing of these, I honestly don't know, because we order them at a company, so I don't know how they specifically manufacture them. But one approach was to deposit the filters directly on the face of the fibers, essentially, but it requires some very specific equipment to actually do this, and get these thin films deposited. So you have, because in the center you need the center fiber, you need a bandpass filter, and then the surrounding fibers you usually need some sort of long pipe filter.
Yeah, sure. So, but you outsource all of that fabrication. You get a company.
We don't do that ourselves.
Yeah.
No. And one thing to mention is for the confocal one, actually, we showed here, right? You don't even need the filters, right? If you look at the high wavenumber range, you don't even need any filters whatsoever in the fibers itself.
Yeah, so that actually makes it a little bit simpler in terms of fabrication challenges. Yeah, great. Okay, we have one final question for Anita that's come in the chat, so we'll have to make this the last one, I think, because of time. So Anita, would you consider anything such as frequency comb spectroscopy, photoacoustics? I think the question here is really focused on when you're looking at the 2 millimeter range. You obviously talked about a number of different techniques. Do you think that there's any sense in looking at those alternative techniques, frequency comb spectroscopy, photoacoustics, that sort of thing, for those sorts of depths?
Yeah, so I'll go back to what I said. It's important to understand what we need to do clinically. We need to be able to measure with 50 to 100 micron resolution, so 2 to 4 cells. We need to be able to scan this 3 millimeter lump, and we need to be able to look in depth still with that 2 to 200-ish axial resolution as well. When you start doing that, you find that many of these techniques, and you want to do tumor versus not. I mean, you want to make sure that you're finding DCIS and IDC as well. When you start looking at that, photoacoustics is great for scanning, but not for resolution. That's the limitation of photoacoustics. You can go through, I mean, people are trying all the different techniques. They all have limitations. What we arrived at was that while Raman is still weak, it addresses all 3 challenges by the way we've configured it. Like OCT is used, and OCT will do great scanning, can do the resolution, but can't really go 2 millimeters in a highly scattering solution, media like breast tissue. It can only do a couple of 100 microns. And so OCT folks are trying to combine that with various forms of molecular targeting agents to increase contrast and be able to go in depth, for example. So every technique, you know, it's a question of what you want to try to do as to which technique is best suited. And I think that's the important thing, to really understand the clinical challenge and therefore use the technique rather than saying, well, I know how to do photoacoustics really well, let me apply to breast cancer, without considering, is it going to be good enough for that problem?
Yeah, I completely agree. I think that's a really nice message to end on, is that, you know, all of these techniques potentially have great potential for a variety of different applications, but it's about finding the right one for the right clinical area, and certainly avoiding this idea of using a hammer to find the nail, as you mentioned. Fantastic. Okay, we've just run over 5 o'clock, so I think we'll call it a day there. So thank you to everyone for signing in. Thanks again to our 3 speakers for giving us their time and giving some fantastic talks. It was certainly from my side very, very enjoyable. But anyone who wants to watch the talks again, some of the talks will be available on YouTube if you care to watch back. But thanks again for joining, and look forward to seeing you all at the next Hamlin Symposium workshop.
Thank you, Alex.
Thanks again.